Good afternoon. It is too late. Long session. Like tricuspid valve area is a neglected valve in adult cardiac surgery. I'd like to thanks to the organizing committee for asking me to deliver this talk. You know the heart valves. I don't have to tell you. It has got 4 valves. And you must be amazed to know that who described first in probably 14th century during Italian Renaissance that all valves should open and close completely. Otherwise, the heart will not function adequately with the regurgitation of blood in the atria from the ventricle. This person who described this was born during Italian Renaissance in year 1400, Leonardo da Vinci, and we cardiac surgeons and cardiologists will remain indebted for his initial observations. He's an universal genius and multifaceted talents, and you know all about him. Actually, the William Hunter, 300 years later, he defined Leonardo as the greatest anatomist of his time and probably his all times. And he managed to observe and to study the anatomic drawings and annotations of Leonardo. Now let us come to the point. Tricuspid valve repair. Why? I've been asked very specific questions. Why and when and how? You all know this tricuspid anatomy is very complex anatomical features you can go through, and this complexity, the cardiologist may find difficulties when they are trying to do transcatheter interventions. As you know that this is the largest and the most apically positioned valve of the 4 valves, and the normal TV annulus is D-sepate and 11.2 centimeter, and a diameter of 28 millimeter. As I mentioned earlier, the tricuspid valve was, especially in adult cardiac surgery, was very much neglected. Earlier, tricuspid valve function was thought to be the less important than the aortic and mitral valve. And moderate to severe tricuspid regurgitations, we thought that can be managed clinically. But now the scenario has changed. And if uncorrected, the left-sided heart failure can progress to right-sided heart failure. Why tricuspid repair? You can see that 5-year survival with severe tear and of LV ejection fraction of heart failure ejection fraction of 34%. The tricuspid regurgitation, the marker is annular dilatation greater than 34 millimeter in diastole or less or greater than 32 millimeter in systole. Tricuspid valve repair, when and how? That depends obviously upon the etiology of the tricuspid regurgitations. Let me talk about something about it. The primary tricuspid regurgitations with abnormal valve morphology. First comes is the Epstein anomaly, and the acquired tricuspid regurgitations. You can go through this series of causes: myxomatous, degenerative endocarditis, carcinoid, rheumatic heart disease and chest irradiation. And lastly, the iatrogenic. That is, you will come across, or you have come across, the pacing leads, transvenous pacing leads causing severe tricuspid regurgitations requiring interventions. And the second thing is functional tricuspid regurgitations with normal valve morphology, which can be ischemic or non-ischemic, cardiomyopathy, aortic and mitral valve disease, pulmonary artery disease, and pulmonary vascular disease. These you all know the algorithm of the pathogenesis of tricuspid regurgitations in mitral valve disease. I don't have to go through. I will go through quickly the causes. The functional tricuspid regurgitation is highly dependent on annular dilatations, and which is different from the mitral valve regurgitations, where they require 75% annular dilatation needed for severe mitral regurgitation. In contrast, only 40% can do tricuspid regurgitations. That you all know is that. Now, I cannot go through all the how we repair all types of tricuspid regurgitation, but I will go through first. I have to touch it. Epstein anomaly, which is a very common congenital anomaly. You know, it is the origin of the septal and the posterior leaflet are displaced downwards into the RV, and the leaflets are usually deformed. Actually, the anterior leaflet is becoming cell-like, and that you all know, and it can be associated with atrial septal defect. When we repair Epstein anomaly, only in symptomatic cases with severe right heart failure and cyanosis. It can be mild in children. They do not require any kind of surgery. In my early years, I did repair a couple of young adults here, and but I am now following a patient now also at the age of 55 with a Epstein anomaly, but she is doing fine. So I don't think she will require any surgery. Now, the goal of surgery in Epstein, as my Devasis is here, he is doing this routinely to mobilize, to normalize as much as possible the position and the function of the tricuspid valve, and to reduce the atrializations of the right ventricle. But what is the reparative technique? There are two types of techniques, you know. One is Danielson technique, which can be Danielson modified with a ring. Danielson technique is the plication of the atrialized portion of the RV. And another is Carpentier repair, which is much more aggressive than the Danielson. I prefer Danielson than Carpentier when I used to do congenital. The pacemaker lead-induced severe tricuspid regurgitations, which is very common. And in my personal experience, I have repaired a couple of tricuspid valve with cardiopulmonary bypass. Is a resection. It may require resection of the leaflets and repair of the resection of the deformed tissues and repairing the leaflets, the pericardial leaflet reconstructions, or it may require Gore-Tex cord replacement. Lastly, we have to do that. We have to put an epicardial pacing lead for pacemaker function. The surgical repair of tricuspid repair when we require functional tricuspid regurgitations, which is annulus is greater than 40 millimeters in diameter, or 25 millimeter square is preferred treatment for functional TR. This is the AHA, ACC, and ESC guidelines. You can go through this, and we all know that the tricuspid valve, first point is that it is highly recommended that during mitral valve surgery, in case of severe tricuspid regurgitation, they should undergo left-sided surgery. And you can go through, and nowadays, I think cardiac surgeons are much more concerned about leaving the tricuspid valve unattended, which I do, and also mild to moderate TR, I normally repair it with mitral valve replacement. And I've seen that postoperative progress is much better in those situations. The principles of all surgical TV repair is that restore the full leaflet mobility, correct the leaflet prolapse, and establish large leaflet coaptations and the reduce and stabilize the annulus. Now, what type of surgical repair surgeons consider? In general, the ring annuloplasty of the tricuspid valve is preferred over direct suture annuloplasty because of decreased incidence of residual or recurrent TR and the need for reoperations and increased patient survival. Now, that varies from surgeon to surgeon. The ring annuloplasty requires much longer time, at least half an hour to 40 minutes cross-clamp extra time. That you have to consider. Now, earlier days, surgeon used to do suture annuloplasty, which I mostly do. First, suture annuloplasty and De Vega technique, you know all, the De Vega suture annuloplasty, but I personally prefer quick operation is the K bicuspidization technique, where you obliterate the posterior leaflets of the tricuspid valve, and it does function very well. It's very quick, only take 5 minutes job, open up the right atrium and do the job. It does very well. Or the annuloplasty ring technique. This is the De Vega technique. De Vega described this for long ago, and it is still a very, and there are lots of modifications of the De Vega technique. Every surgeon, they modify the technique. They put Gore-Tex strip, they put partial De Vega technique just in the posterior leaflets. So it does well actually, and it does not take that much time in doing the ring annuloplasty. This is as you know, that because I have not put any videos or something which is very time consuming, and in this short talk, it is better not to put video, keep the thing simple. And this is just the tailor-made annuloplasty ring, and all surgeons who are familiar with that, it is very easy to implant, and there is nothing in it. Let us talk about the functional tricuspid regurgitations. Now, the transcatheter repair, that is very important, because I cannot finish my talk without saying how the cardiologist, they are venturing in this field of cardiac science, because they have already captured a lot of things, and I have to, and this is for cardiologists, they'll be feeling very much happy to note that in times of change, the learners inherit the earth, while the learned find themselves beautifully equipped to deal with a world that no longer exists. You see, I have to keep the cardiologists very happy, because because the cardiologists, they have already, capturing, they are leaving no stone unturned in the cardiac science, and they have taken out the, the coronary artery disease, the aortic valve disease, and a lot of other things. So this tricuspid is very important, but you have to see whether this quote, Eric Hoffer is a fantastic man, and he is a quote writer, and he was awarded by the Presidential Medal of Freedom. He writes lots of quotes, and I thought this is very much important in this meeting, and you will say, yes, it is appropriate or not. Transcatheter repair of functional tricuspid regurgitations. It is an emerging therapy. In patient with functional tricuspid regurgitations with left ventricular ejection fraction less than 40%, severely impaired right ventricular function and pulmonary hypertension, where the surgery will carry high risk. So these are the cases we should go for transcatheter repair of tricuspid regurgitations. The primary challenge, however, in the development and utilizations of transcatheter devices, the complexity of the anatomy and the closeness of the AV node, coronary sinus, right coronary artery, aortic valve to tricuspid valve. The patient selection is important, which is done by the CT and echocardiography for deciding the appropriate procedure and device. Am I late? Going late? Okay, 1 minute. Transcatheter repair is ace to ace using MitraClip or TriClip, Abbott Vascular, or the Pascal Clip, Edward Life Sciences, and the Forma special device for leaflet coaptation, and the tri-align or cardio band devices designed to decrease the TV annulus dimension. The MitraClip is the most commonly used device in 80% of the cases and can be repositioned or removed. I don't have any experience. I am a cardiac surgeon. Cardiologist will help me to say which device they use. Additional clip can be implanted for adequate tricuspid regurgitation reduction. Recently, MitraClip has been modified to TriClip to facilitate the bending maneuverability of the device in RA and RV coaptations. So you are the best judge. The tri-align technique is the replication of the surgical K bicuspidization technique. Here, the devices, they occludes the posterior leaflet of the tricuspid valve, making the tricuspid valve bicuspid. However, this requires a lot of clinical trials and safety and quantify decrease in severity to tear severity, its efficacy and outcome on the patient's outcome quality of the life. Recently, I was reading in the New England Journal of Medicine. It came out in 17th of May, and you may know the Soibal Kaur, who is the son of Sisi Kaur, and he was the investigators, and they have found very excellent results of this transcatheter technique. Lastly, I will say that a multidisciplinary team approach is needed. A cardiothoracic surgeon, interventional cardiologist, echocardiographer, anesthesiologist, and the patient's primary physicians. That's the way we can go forward. Thank you.